Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. We keep hearing a lot about RSV, a respiratory virus that affects an estimated 64 million people and causes 160,000 deaths worldwide each year. So now there is a vaccine that can help fight it. But how safe are they? Who should get them? And what is the RSV and how does it compare to the flu and COVID? Let's get these answers from the expert at Northwell Health. Our guest today is Dr. Matthew Harris, a pediatric emergency medicine and EMS physician who is triple board certified in General Pediatrics, Pediatric Emergency Medicine, and EMS Disaster Medicine. He serves as the medical director for the Cohen Children's Medical Center Pediatric Critical Care Transport Team and an associate medical director for Northwell Center for Emergency Medical Services. Dr. Harris, welcome to Your Family's Health on the Voice of Nassau Community College, 90.3 WHPC. Welcome.
Thanks so much for having me.
So tell me a little bit about you and why you decided to dedicate your career to pediatrics.
Sure. Well, I think I've known for a long time that I have a propensity for interacting really well with children. I think my parents tell stories from when I was a young kid about running to kids who fall in the parking lot and seeing if they skinned their knee. So when I got to med school, I found myself very quickly gravitating towards neonatal medicine or pediatric medicine. And pediatrics just became a great fit. I think, children represent a really unique and challenging clinical environment, if you will, for pediatricians. So the ability to diagnose kids who can't talk to you, but also coupled with the fact that they generally get better, right? So I get to send most of those kids home and know they're going to do well. It was just very a natural thing for me. I'm a parent of 3 kids, and that has just sort of reinforced. I think I'm a better doctor now that I'm a parent, and hopefully a better parent now that I'm also, a pediatrician. And so this has been a very natural evolution for me over the past, 13 to 15 years.
So what is the age range for pediatrics? What ages do you see?
That's a great question. So at Cohen Children's, where I work clinically, we see in the emergency department really from 0 days old, mostly up until the age of 18. We do see some young adolescents who are in their 19, 20-year-old range if they're followed by a subspecialist here. For example, they have sickle cell disease or cancer or neurologic issues. But generally speaking, it's from birth till 18 years of age in our emergency department.
And then it's just a natural referral over to adult health kind of practitioners or general health
Yes, that's a really important point. So the transition, especially for medically complex children, the transition from pediatric or adolescent medicine into the adult world of medicine can be very challenging. I know that the team here at Cohen's works very, very carefully with those families to identify the right providers for them. And there's actually a whole field of providers who are dual trained in both pediatrics and internal medicine who really have formed an important bridge in that gap of care.
That's great. So can you explain in easier terms, what is RSV?
RSV is something that probably every one of your listeners has had. It is, for almost everybody, a common cold. So if you have had a runny nose and a cough sometime between November and March, anytime over the past, 100 years, you have probably had RSV. We don't frequently test for it in people who are outpatients because there is no treatment for RSV, though we will talk about some of the prophylactic opportunities we now have in the form of vaccines and immunoglobulins later, monoclonal antibodies rather. But generally speaking, it's a common cold. The issue really is that there are some populations that are at higher risk for the sort of sequela or complications of RSV. And that's really young children under the age of 2, children and adolescents who are immunocompromised, and the group of folks 65 years and older. And that's just because they're at higher risk for pneumonia or dehydration or those things that are really the secondary side effects of the primary RSV infection itself.
So what is the distinction between RSV, the flu, COVID, and other, those very common respiratory infections? Can you tell us the difference? What makes them distinctly different?
It's a really important question. So, there are thousands of viruses, right? So it's a common conversation with parents. And I want to know what virus this is. And while there are these large viral panels that are available, the reality is that with the exception of flu and COVID, which we'll talk about in a moment, there is no treatment for these viruses. So for most part, even knowing which virus it is really just an academic question, because they all last 5 to 7 days. Kids will often cough for 1, 2, 3 weeks after these viruses. They're all genetically a little bit different. And so the common cold really is a bit of a misnomer, because it could be enterovirus or rhinovirus or RSV or parainfluenza. So these are all just different viruses that cause fever, cough, runny nose. And then in a select group of population may cause more trouble breathing and, again, failure to drink well, and then dehydration. In particular, I'll point out that flu and COVID are two of the main viruses that we offer treatment to, again, for select populations. So the flu, and I should say that, flu and COVID are either vaccine preventable or vaccine, what I call mitigatable diseases. So no vaccine is 100% against viruses, but it's like wearing a seatbelt. It won't prevent the accident, but you won't get as hurt as badly. So everyone should go out and get their flu shot. Everyone should go out and get their COVID shot. But since we can't prevent illness in everyone, there are people who are at higher risk for flu and for COVID. Again, children and adolescents with severe asthma, with cancer or sickle cell disease. And so those patients can be treated, depending on when they present, with a medication like Tamiflu, which is an antiviral medication taken by mouth for flu. There are other oral medications for flu that are less common but available. And there's a slew of new medications. Probably the most famous one on the market is Paxlovid, which I would recommend you speak to your provider, just because there are lots of medication side effects with Paxlovid. But really, flu and COVID are the two viruses that in the right population and in the right time frame may benefit from treatment.
So that medication is given for all of those 3 viruses that I mentioned. Is it necessary to actually come in for a diagnosis and to, do a nasal swab, or what do you do to determine which infection it is?
Two really important questions, but just a clarification. Paxlovid is only for COVID. Tamiflu is just for flu. So then there is no treatment for the other common colds, except, chicken soup and Tylenol and lots of water. And so for the average healthy vaccinated person, whether they're 2 years old or 75 years old, who's healthy and doesn't have underlying medical problems, no, there's no reason to be tested just because you have fever, cough, runny nose, maybe a little bit of cough. If you are short of breath, if you are vomiting, if adults are having pain in their chest, if kids aren't drinking and haven't, in that age group, haven't produced a wet diaper in 8 to 12 hours, those are reasons to get seen either by your primary care provider, or if you're having significant distress, the emergency department setting. But no, there is really no indication for the average healthy 4-year-old with runny nose and cough for 4 or 5 days, who isn't wheezing, who's drinking and doing everything they need to do. No reason to be seen, no reason to be tested. It might be worth a phone call or a televisit with your primary care physician just to make sure they can give you guidance about what to look out for.
So if I have a child who's 4 years old, for example, and has a runny nose and maybe they're febrile, have a high temperature, I don't need to make my way to the ED, the emergency room, even though they're symptomatic? You don't think that's necessary?
That's a question I think most parents ask themselves really frequently. When do I say it's time to go to the emergency department? Number one, I think you have to look at the child, and obviously if you're at all concerned that the child is having trouble breathing, is ill appearing, of course, every emergency department, especially children's hospitals, would encourage people to be seen. But if it's just that you've had a fever, 102, 103, 104, maybe it's not coming down. And the reality is with viruses like the flu, sometimes you just have fever for 7 days and there isn't enough Tylenol or Motrin in the world that's going to make that fever break. And that's just the nature of the illness. And that's okay. And it's not dangerous. So I think if kids are having, minimal symptoms, so cough, runny nose, maybe not drinking as much, but look well, I think the first call should be to the pediatrician. The emergency department really is for children who need emergent care now. They're not breathing well. They're not as responsive as they should be. They haven't drank in 12 hours and peed in 12 hours. And that really should be how we target, and how we direct as physicians and pediatricians people to the emergency department.
So what are some of the preventable measures that you would suggest for mothers, fathers, parents, or those caregivers to prevent the virus from happening?
Yeah, get vaccinated, right? So there has been a significant decline in vaccinations for many vaccine preventable or vaccine mitigatable illnesses. All over the news around the country, and even here in our neck of the woods, are cases of measles, which is, overwhelmingly preventable by vaccine, right? And a vaccine that's been around long before me and will be around long after me. So vaccination against the flu and COVID, depends on the year. Sometimes it's really effective, sometimes it's less effective. But we know is that it reduces transmission. It makes the disease burden lower for the patient and the community. And less people are going to get hospitalized with the flu or with COVID if they get vaccinated. Beyond that, I think, listen, we saw essentially no flu and no RSV during COVID. I mean, I think we had one case of RSV in like 8 months during the height of COVID, and that's because everybody stayed home. Mm-hmm. That's not our reality anymore. We certainly don't want everyone to live in a bubble again. Mm-hmm. Those times are very dark. But what it shows you is that if you're sick, stay home. If your kids are sick, don't send them to school, right? Because all these other viruses will spread, and whether it's something really as serious as measles, or whether it's something mild like the common cold, the reason I'm coughing is probably because I'm around people who cough, either at kids' school or at the park. Right. So I think these diseases are communicable, right? They're easily transmittable. So washing your hands, I will tell you, the masking recommendations have all come down. I still mask in places like airplanes and on the subway. It's a personal choice, and it's a personal choice for your listeners as well. But washing your hands, don't go to work sick, don't send your kids to school sick. Sometimes it's a bit easier said than done, but those are the really, preventable ways to reduce the illness for both the patients and the population.
You're listening to Your Family's Health on the Voice of Nassau Community College 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about RSV, a respiratory virus, and the vaccine available to help fight it. My guest today is Dr. Matthew Harris, a pediatric emergency medicine and EMS physician with Northwell Health, who is triple board certified in General Pediatrics, Pediatric Emergency Medicine, and EMS Disaster Medicine. So, Doctor, you mentioned the upsurge of measles. Why does that happen, and why is that happening?
It really is a function of vaccinations, right? So we have seen a significant decline in parents obtaining even standard vaccinations in the post-COVID pandemic. A lot of that is hesitation about the COVID vaccine itself, and perhaps the way it was communicated by public health officials and so forth. But in Nassau County, for eligible children, I believe it's under the age of 12, I'll double check, only 4 out of 5 kids are vaccinated against measles, mumps, and rubella. It means 1 in 5 children is not fully vaccinated in that age group. And this is remarkably transmissible. I mean, the number of patients in a local area, if a kid is coughing who has active measles, will spread like wildfire. Mm-hmm. And that's why we're so cautious about this. And I think this is something we're certainly working through at Northwell and throughout the Department of Health and other key players about how do we continue to push this message out of how important vaccines are for these illnesses. And I think, we see a handful of measles cases every year. They tend to be in patient populations that are under-vaccinated. But it means it's out there, right? And this is totally preventable. And it really is a responsibility. I say this as a parent. It's my responsibility as a parent to protect my child. And the best way to do that is through vaccination, especially for vaccines like MMR, which have been around forever. Evidence-based, clearly reduce the disease burden. Mm-hmm. So I encourage parents to have those conversations with your pediatrician or family medicine provider. It's critically important for your child and for the public safety to be vaccinated.
I know there have been some concerns with parents with vaccinations. What do you say to them in terms of educating them and encouraging them to have their children vaccinated?
Anytime somebody further recommends a medical intervention for a child, parents have the absolute right and responsibility to say why. So it is our responsibility as pediatricians to show them the data and show them the impact of vaccinations, to show them the downhill effects if they're not vaccinated. And, I remember in medical school, I saw a child die of the measles, and that's really rare. We should say the majority of people who get the measles, thank goodness, have like a moderate clinical illness and they get better, but you can die from the measles. So I think it's the conversation between pediatricians and parents is so critical. And that's a trusting relationship that you actually don't see in a lot of other medical doctor-patient relationships. But the relationship between a parent and their child's pediatrician is so critical to this. So I try to be data-driven. I try to talk to them about what I do with my children. I'm with my money where my mouth is. Right. Because I think they hear me when I say, listen, as a father, this is what I do to protect my kids. And as your pediatrician, even for the day in the emergency room or back when I practiced general pediatrics, we have this shared responsibility to make the important, correct decision for your child. And I think you start there. There are some people who are just very vaccine hesitant. And my experience has been that's really based on things on social media. And so how do we regain their trust that clinicians are the trusted partner and not the TikTok influencer?
Very interesting, because I know it is a requirement for school-aged children to be vaccinated. So are you seeing more and more children coming to you unvaccinated?
So we should be clear that public schools require certain vaccinations.
Yes.
Private schools do not always require vaccinations. And there are exemptions to vaccination for several things. And some of those exemptions are very legit. There are some children who have medical reasons that they can't get certain vaccines. So I certainly don't want to lay any unnecessary shame. There are some families who cannot give it. They had a severe allergic reaction to the first one. They have a medical reason why they can't get certain live or what's called live attenuated viruses, which is kind of a very weakened version of the virus. So there's a patient population out there that can't get it. That's really, really small. But yes, we're seeing an increasing number of people who have said, you know what, I'd rather homeschool than vaccinate. I'd rather take them to a private school than vaccinate. And instituting vaccines as a requirement for school was a public health measure, right?
Yeah.
Because you're taking 30 kids, putting them in a classroom in close proximity. And if one of them has the measles and the rest aren't vaccinated, the rest will get the measles at some point. Measles being really highly contagious. So, this is something we have to deal with, but I think we need to re-engage with parents. We need parents to be willing to listen to us too, right? Not to be told what to do. I think those days of the 1950s physicians saying, you're going to give these vaccines, it really is about engagement, redeveloping that relationship of trust, and then showing them ultimately, hey, look, this is out there, right? We're seeing kids with measles. We're seeing kids with streptococcal meningitis, right? Neisseria meningitis. And these things are fatal. And that's a decision you can't unmake.
So what is the potential long-term consequences of severe RSV or any of the infections that you just mentioned?
Yeah, maybe we'll focus on RSV for a second. So first of all, I should say that again, the majority of kids with RSV, fever, cough, runny nose, they're a little miserable for a couple of days. I will tell you, having had RSV this year with my youngest, I was miserable for a couple of days, coughing, didn't feel great, but we all got better. The highest risk patients, kids under the age of 2, they tend to wheeze or have something called bronchiolitis, which is some inflammation of the lungs. And that's typically a short-term problem, right? A couple of days, maybe a week. But many of those kids have to be hospitalized, especially kids under 1, because they're working so hard to breathe because of how inflamed they are. And the kids who are at the highest risk are actually infants, because RSV, for some reason, often tells the baby's brain to stop breathing. They become apneic. And that's actually a very common reason for apnea in kids under the age of 2 months. That itself is pretty rare. Now, there are some associations between having severe RSV and going on to have a higher incidence of things like asthma or reactive airway disease. But generally speaking, having RSV once, twice, 4 times as a kid, and it's really common. There's so many different versions of RSV that you will have RSV many times in your life, right? So developing immunity, lifelong immunity is really, really hard. And when we talk about vaccinations in a few minutes, that's why we're really looking to protect people in their highest risk groups for a select period of time, right? So, when we talk about the group that's 60 and older, we want them to get this just before RSV season to protect them, like the flu shot. You're not protected from flu forever. You're protected for 4 to 7 months. RSV, the same thing. For expectant mothers, the newborn infants are at extraordinarily high risk for RSV. So how do we protect them? We actually take advantage of biology. We let mom get the vaccine before birth. Mom develops antibodies, and then mom's antibodies are protecting that baby. What another incredible thing we ask of our mothers. So this is really, the emergence of the RSV vaccines in the last, 6 to 9 months has been really, really important, not in preventing all RSV disease, but in limiting the number of children who end up on ventilators in the emergency departments in the ICU.
Let's switch to COVID. So the WHO says that we're still in the pandemic, but how are we now treating the COVID virus? And is it as fatal as it once was? And if not, so why?
Yeah, so, it's hard to believe now, just past the 4-year mark from when COVID was declared a pandemic. And I'm actually, just on a personal note, I am 4 years and 4 days after I was hospitalized, for COVID. So this is something that's very, very, very close to home. Thank goodness, right now, the variants of COVID out there, for the majority of people, it's really become a more commonplace virus. Fever, cough, you feel miserable and achy and tired for several days. But for the most part, people do get better. Okay. So I think we are in this current phase of the COVID pandemic, I think we're out of the hyperacute stage where, 4 years ago, hundreds of people on ventilators every day, hundreds of people dying every day. Now, there are still people who are at really high risk. And if I sound like a broken record, it's because they're always at high risk.
Yeah.
People 65 and older, people who are immunocompromised. So if your body's having difficulty fighting infections on a regular day, COVID is bad news. Now, the good news is that over the course of the past 4 years, we've seen a series of advancements in how we treat COVID and now how we prevent COVID. Now, vaccines definitely wax and wane in their efficacy. We know that when you get vaccinated, it reduces the likelihood of getting hospitalized, it reduces the disease burden, but it doesn't mean you will not get COVID. It makes you less likely to get COVID. So vaccination remains a mainstay of a vaccine mitigatable disease. There are now some treatments for COVID. And again, I think we just discussed Paxlovid. No financial interest here. Paxlovid is probably just the best marketed of all the different oral COVID medications. It's meant for patients who are outpatient, right? They do not require hospitalization. And those are for patients with asthma, diabetes, they're morbidly obese, they are immunocompromised. Now, I should say that Paxlovid interacts with many, many, many medications, which is why it's not over the counter. It requires a prescription, and your physician must go over your medication list to do that analysis of, is it worth it to either stop one of your medications or be aware of side effects. I think probably the biggest advancement in the last couple of years has just been the way we treat COVID. So again, at the height of the pandemic, we had monoclonal antibodies, which have waxed and waned in their efficacy depending on the virus itself, and right now are not a mainstay of treatment. Remdesivir, which is an intravenous antiviral medication, is still indicated in a subset of patients getting hospitalized, or we do a 3-day course of IV remdesivir for patients we're trying to keep out of the hospital. Patients with cancer, for example, where being in the hospital is a risk. So there are some places that will offer remdesivir and some steroids and things as an outpatient. But our ability to treat what's right now a less life-threatening disease is, I think, in a great place. We just have to be aware that as people move away from vaccination, which has been the trend, it is very possible and even likely that we'll see another very lethal variant. So we really have to be diligent.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about RSV, a respiratory virus, and the vaccines available to help fight it. My guest today is Dr. Matthew Harris, a pediatric emergency medicine and EMS physician with Northwell Health, who is triple board certified in General Pediatrics, Pediatric Emergency Medicine, and EMS disaster medicine. So, doctor, you mentioned the vaccine for RSV. You mentioned the vaccine for COVID. What about the flu shot?
Gosh, I mean, everyone should get their flu shot. I will tell you that I think we keep hearing the term triple-demic. Certainly last year was an incredible experience as a pediatric emergency medicine physician and also as a father to watch tens of thousands of children in our immediate region get sick with either RSV, flu, or COVID, and many of them got sick with all three. So, the flu is a vaccine preventable or mitigatable disease. Certainly, every year, every children's hospital, we all talk about that 1 or 2 kids who die from the flu. Mm-hmm. They die from the flu, and some of these are healthy kids. They weren't vaccinated. So I think that the flu vaccine, again, it's been around for a long time. It's modified each year based on trends around the world to try to mitigate, again, to diminish the burden of flu infections. But it's really incredibly important to get vaccinated against the flu.
So what is the timetable for all of these different viruses in terms of the vaccinations? Are we doing it together? Are we doing it separate? Are we doing it every year, every 2 years? What is the timetable?
Yeah, great question. So let's talk about the flu. So the flu is an annual vaccine, right? It protects you for 4 to 7 months, and then its efficacy wanes, right? So, but that's fine because in the United States, the flu season is roughly November-ish till April-ish. It depends on the year, but it's roughly when it is. So there's no benefit to getting vaccinated against the flu in June because it'll already begin to wane by the time it begins. So most people go off and get their flu shot in September, October. December is kind of cutting it late because you want it to optimally protect you during the height of flu season. RSV historically has been a winter time pathology as well, though we do see it all year long. And again, infants, we'll talk about this in a second. Infants are particularly at risk all year long for RSV, but the bulk of RSV is when people are indoors and coughing on each other, right? So October till March, October to April. We'll come back to the RSV vaccine in a second. COVID's tough, right? I think we'll start moving more towards COVID being a more seasonal disease where really, again, people who are inside and we don't have the benefit of fresh air and you're not playing baseball on the field, we're playing basketball inside. My hope is that it becomes seasonal. That'll certainly be easier from a public health perspective to make recommendations on vaccination. But let me jump back for a second and talk about the three groups of people who benefit most from RSV, because unlike flu and COVID, where there's basically a universal recommendation for vaccination, again, pushed a little harder in high-risk groups, the RSV vaccine is a little bit more targeted. So I'm going to break down that for you now. Adults who are 60 years and older, who are considered high risk for the serious RSV infection, RSV pneumonia, are really recommended to get that shot once a year, sort of late summer, early fall, just before that big bulk of RSV begins to spread in the community. So that's once a year before RSV season. Those for adults 60 years and older, and just the age cutoff being enough to say you are at high risk. So whether you're well or immunocompromised, if you're 60 years and older, have that conversation with your doctor. But the Center for Disease Control recommends vaccinating 60-year-olds and older once a year just before RSV season. When you look at infants and children, again, infants being at really, really high risk, two ways to protect infants. One way is that mom can get vaccinated somewhere in the later part of her pregnancy. The recommendation is between 32 and 36 weeks. It's kind of like right at the beginning to middle of the third trimester of pregnancy. And the idea is that gives mom's body enough time to build those beautiful antibodies that she's building, and that those get passed through both the placenta and breast milk eventually. So many ways to do that. And there's actually only one vaccine for RSV that moms take, and that's the Pfizer vaccine, which is called RSV. And that's the only vaccine that's right now approved for RSV during pregnancy. The other way to protect kids is to give infants their first dose of a monoclonal antibody. And I think this has been probably the shining light of the COVID pandemic, as we reaffirmed this technology that's been developed over the last 10 to 15 years of developing monoclonal antibodies. So nirsevimab is a monoclonal antibody. It's recommended to be given to infants who are 8 months and younger, who are born during RSV season. So basically, if they are going to be born or under 8 months between, again, October and March-ish, they should receive it. A second dose is recommended sort of later on in life when they're 8 to 19 months if they're at increased risk. Now, so again, to be clear, all infants are going to be recommended to get this if they're 8 months and older and born during RSV season. For those kids who are at risk, it's really kids who have underlying diseases like they're premature. They've been developed reactive airway disease. God forbid they're young and have cancer. They should get that as they enter their second RSV season, which is their second year of life.
Well, thank you so much. A lot of information and great information that we need to go moving forward. Thank you for being here, Dr. Matthew Harris, a pediatric emergency medicine and EMS physician with Northwell Health, who is triple board certified in General Pediatrics, Pediatric Emergency Medicine, and EMS Disaster Medicine. We thank you for giving us this very important information, and we hope you continue to stay healthy yourself and your children and keep doing the great work that you're doing.
Thanks so much for having me. It's been a pleasure.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.